I'm Mark Campbell. I'm a medical oncologist in Grand Rapids, and I'm going to try to help you understand how cancer grows and spreads. How cancer grows and spreads. And again, I'm going to cartoon-like illustrations to take a complex situation and hopefully make it a little bit more understandable. Typically, when we find cancers, they're an inch or two in size. My mom had a lung tumor. It was 3 inches. Had a man not too long ago had an 8-inch kidney tumor. So it's not unusual. Deeper in ones can get pretty big by the time they put pressure on some adjacent nerve or structure to draw our attention to it. One's out near the surface of the skin, maybe a lump shaving, maybe a lump in the breast if it happened to be out near the surface. You're going to feel them earlier and they're going to be smaller. But most cancers are in that kind of size range. If we take only a ½ inch of cancer, smaller than the majority, a ½ inch of cancer equals 1 billion cells. It takes 1 billion of those stinking little things, piling one on top of another, on top of another, and another, in order to equal only a ½ of an inch, let alone the more typical sizes of an inch or 2 or 3. So the first point I'm trying to illustrate on these cancers are they're made up of many, many, many cells, point 1. Point 2, they're very tiny. You can't see the darn things. If it's sitting right in the palm of my hand and we're looking right at it with our regular eyesight, we can't see it. So there's lots of them, and they're very tiny. So if you're going to be stuck with cancer, would I rather have a big one or a little one? Well, the answer is I'd rather have whichever one stays put usually. Even if it's bigger, if it stays right there, I know right where it is. I can keep my eye on it. I know where the enemy is. Versus a little one that maybe has broken off seeds and are shedding seeds here and there. If I knocked over this little bowl of sugar on the carpet and said, oh boy, and now I got to pick through the carpet, I could easily miss one. Hardball falls off the shelf, no big deal. Put it right back up on the shelf. We know right where it is. Why does this one stay so nicely together and this one spreads seeds very around early? We don't always know. But it's not like you can't deal with either one of them. But it's a lot more hassle if you've got to try to run down all of these little seeds that can be any nook or cranny, and you can't see them to know it. The other corny way that I like to explain that is if you have a dandelion that's blown some seeds from the neighbor's lawn over onto your lawn, it's not enough just to go and pluck the dandelion. We've got to get the little seeds too, or they'll come right back and haunt us next April. The other corny way, it's not corny, but it's sad because it happens so often, but somebody can come in and pain in the bowel, they find out they have a cancer in the bowel, they immediately that day remove it. Everything's fine, but 2 years later, they've got cancer cells growing in the liver that had come from that tumor prior to the surgeon even knowing it was there. So those seeds that migrate and then lie dormant and then come back and sprout next spring, those are the ones that give us the heartaches and the trouble and the systemic spread that we have to deal with. I'd like to illustrate a couple other points using my mom's lung cancer as the example. She had a 3-inch tumor right there. Now, if that's her only problem, 3-inch tumor, no big deal. Remove the lower half of the lung and you're good to go. So if it's in one spot, surgery's quick and easy and usually effective. But what if the seeds broke off already? What if the horse is out of that barn? Well, now focusing just on the barn is not going to get the job done. Does that mean we're tough out of luck? No, it just means we've got to do something to kill those seeds. Well, if they broke off and they stayed in one area, we could, in the case of lung, we could add perhaps a zone of radiation. Radiation's like a chest x-ray. You stand there, some ray goes through the air, you don't feel it. They can aim it at your ankle or your knee. They can aim it at the area between the lung we call the mediastinum. And why are they so successful? See, the radiation doctor doesn't need to be able to see it to kill it. If they know it's in that area, they could just treat that whole area. Surgeon, on the other hand, they have to be able to see it or know exactly where it is so they know how to extend their cut. But it's not possible often to know that that seed was there. But the radiation doctor will say, well, nuts to it. I can't see it. Nobody else can either. I'll just treat the whole area, and that'll take care of it, provided what? Provided it's still in the area. But what if it had broken out of the area, scattered all over my body, my system? So in our terminology, we would say it went systemic. Well, now I must go systemic. I can't just treat one defined area. And the corny way I explain systemic is if I had some germs floating in a bathtub or hot tub, I don't look in there and try to grab a germ. You can't see it. You don't have to. What do? Well, you pour in a disinfectant, chlorine or less oil or something. It immediately goes everywhere, deep end, shallow end, right side, left side. It goes systemic, and I don't need to see it. So whether it's in one spot, or if it changed but went into one area, or if it changed and went systemic, we have to apply a different strategy to each of those issues. We have a strategy for each of those conditions, but we have to know that. And we call that the workup. So a lot of the time, early on in your cancer, we're doing tests and we're doing blood tests and x-rays and the like in order to try to understand exactly where everybody's tumor is or isn't, so that we can apply the appropriate strategy to their care.